This is the DT Podcast. I'm Alex Furchess. This episode is the first of two parts of a conversation I had with Professors Jongh and Suzy Mattijssen. Endlessly iconoclastic, dynamic, and with CVs so long, I won't bother to start to describe them here. You can read that in the notes to the show. So today we speak about the treatment, brief treatment of PTSD, often with comorbidities that are very, very bad, like personality disorders, even dissociative disorders. And they're very successful at what they do, and their research is very solid. Not everyone agrees with their methods, however. They're going to speak about that. In their opinion, this is due to an unnecessary phobia, especially in the EMDR community, of dissociative symptoms. So that's a really interesting conversation. And off the bat, I hit them with kind of a setup question that I knew how they would answer. So in any case, I hope that you really enjoy this episode and that whether you agree or disagree with them, it will challenge you to do what Odd says, which is read the research and do some of your own. Enjoy. Odd, Suzy, welcome to the podcast. Thank you so much for coming. We said today we'd speak about intensive treatment of PTSD. And so this is just something that's common in Europe especially. And I just spoke to Sandra Kamphaus about WeMind, and especially the exposure techniques that are used in Europe can be kind of shocking to not just American clinicians, but American clients who are used to like a humanist kind of therapy. They come in, they expect to talk to their kindly grandmother for several years, you know. He said in the Netherlands, you wait for 6 months, you get 4 to 8 sessions. It's not a preference, it's a necessity almost. So I encourage everyone to read about your facility, Sidetrack, and other research. But my question right off the bat is, what happens when intensive PTSD treatment of the type that you guys specialize in opens up previously highly dissociated trauma, something the client may not initially report, not because they don't want to, but because they don't think of early childhood memories as existing if they don't have images, right? Right. Like I don't buy into the whole repressed memory thing, but we know that even a TBI can dissociate images. Does that ever happen?
Can I say something about that? Because I think it's such a cultural phenomenon. We train people in the Netherlands, and here people are used to do that to symptoms like dissociation all the time, because it's part of the DSM post-traumatic stress disorder symptom clusters that there are. So it's not just like hypervigilance. It's not a problem. But as soon as we go to present in the United States, the first question people ask, but how about my dissociative client? What's happening in in the United States? Why is this such a problem? Are you afraid of dissociation? I can imagine, because I know the background of EMDR. And there were, in the beginning, EMDR, there was no problem with dissociation. But after a while, after the first year, people were saying, hey, but what about our dissociative client? As if there were people with dissociative identity disorders all the time.
Mm-hmm.
We now know, or we still know, that there are only a very small amount of people in the mental health care that have a dissociative identity disorder. Most people have just dissociative symptoms.
Mm-hmm.
You can treat the trauma and the dissociative symptom disappear. The same is what we know, that almost everyone with a dissociative identity disorder also have PTSD. Just treat PTSD. Just treat the traumatic incidents that are causing the PTSD. It's not a problem at all in our intensive treatment units. It's not a problem at all. But there is a fear going on in some countries and not in all countries. Not so much in Western Europe, but particularly in the United States. So please explain why are people so afraid of that, and also are afraid of something coming up from the past? So, of course, if you do trauma treatment like EMDR, you ask people to come up with associations. So people sometimes say, "Hey, now I remember sexual abuse from my uncle, but I just told you about my grandfather, but also my uncle did something terrible to me." And then you say, "Okay, continue. Just stay with that.
Go with
Follow the
that. Right.
track. It's
Yeah.
not that difficult." So if you read the literature for CBT colleagues like Edna Foa, it's not a problem at all. But Francine Shapiro started to talk about that. Hey, dissociation, you have to be careful about that. You have to um, uh, take measures or do clinical interviews with these
Yeah.
patients. It's a strange thing that it's a fear of EMDR therapists much more than any other therapist with from another school.
Yeah, especially the last part. You see that in the States, everybody is used to using certain measurements for seeing how many dissociative symptoms people have. We don't use those measures at all. Yeah, we use them for research purposes to show that you can still treat those people, but we don't use them like for clinical reasons. And so we only use it to show that people with, for example, the dissociative subtype, they react just the same to trauma treatment or intensive trauma treatment than people that do not have the dissociative subtype of PTSD. The only difference is they start a little bit higher in symptoms and they end a little bit higher in symptoms, but their decline
Yeah,
uh,
more
is
severe,
it's
more.
two lines that are just the same. Yeah.
So
So
that's what research shows.
Mhm. So I've got kind of a funny reflection on that from I took one of the very first EMDR 2.0 trainings that you guys put out. It was like 2019 or something like that. It was
correct.
when you had the solid research. My mentor, Jesse Rappaport, was like, "Oh, you got to see this. You got to see this." Because he just turned me on to anything new. But I remember in that training, some American guy said, "But I can't believe that if you have somebody with DID, you just clap in their face." And then,
Yeah,
and Odd, what you said is, "Have you tried it?" And the guy had no response. He had no
that's correct. I
response, which was,
remember that remark. I
yeah, yeah.
remember that remark. Yeah.
It stuck with me as like, oh, okay.
Yeah.
So, but I think I can give you two answers, the bad one and the good one. I think the bad one is that a lot of American therapists come to EMDR from a background that is already like long-term treatment sort of thing. Like for instance, I came from like a hypnotherapy background, right?
Hmm.
So that was so sometimes, for instance, people have read The Haunted Self before they get into EMDR. Perhaps that's how they're led to EMDR. Plus, I can also tell you that my most popular episodes on this podcast are my four, getting ready to be more, with Sandra Paulson. So her work has been highly influential. And I
Yeah.
respect her a lot. She was the person who let me know, oh, there's something more going on. And she's one of my very favorite people. I tell her she's like everybody's dissociation godmother. But there's your different approach right there. Now, the bad reason is some people, unlike her, do not follow the science, do not follow the neuroscience at all. Unlike Dr. Vanderhart, they're not interested in that. And a lot of American therapists are using this kind of pseudo spiritual type approach that can
Hmm.
get very strange. And,
Yeah.
I mean, one therapist, I referred a client to her because I'm always stacked full of clients. And I said, no, I don't. We've been working with, like parts of self or so on. Not that I like doing that. And she said, you don't like doing that? And I was shocked. I was like,
Yeah.
do you want this client to suffer forever? I mean, I do that when I have to. But so that's the bad reason. Now, the good reason is that I have seen, so for instance, I have a client who received EMDR treatment in like 1993. And she didn't remember the first 10 years of her childhood, which is like, if you ask clients, it's like very common. I read your paper on beliefs about memory, which is fascinating, but I'll link to that. But she had those 10 years opened up and her symptoms just blasted open. They were lucky it happened in inpatient because all of that just came back. And one other anecdote, and I could give quite a few, is that a guy received effective treatment for combat trauma. And then his childhood as being trafficked came back, and he had horrific intrusions right down to smells and body sensations of all of the sex trafficking at age 6. So I'm just wondering what happens with that. And this is just a concern when you use intensive treatment outpatient. And the other thing is, America is the world's #1 producer and consumer of child pornography. I hate to say it, but maybe there is something different here. So bad reason, good reason, have at it.
Well, I think there are a couple of things there that are like, we are mixing it up. So first you talk about research and you talk about Dr. van der Hart. The whole theory from not only Anna van der Hart, but also Suzette Bone is about structural dissociation. And up until now, there has been a lot of research done, mainly in the experimental field, with DID patients into structural dissociation, mainly by Professor Raffaele Huntjens. And she has shown that there is always a little bit of memory that when it comes up in, like what you say, one alter, that fluids to another alter. So the idea of structural dissociation, where two alters are not connected to each other, there is no proof of that. It was always a theoretical model. On the other hand, there is no support evidence for it. But that doesn't mean that people do not perceive themselves as being different parts or different alters. They do perceive themselves as being different parts. But then we are talking about DID, so dissociative identity disorder. That disorder is really, really rare. And I think a lot of people make mistakes in thinking that somebody has DID, but in fact, that person has, dissociation, which is just a normal and common thing that we all do. But the amount of dissociation, the severity of dissociation is different. We all dissociate. If we are on the highway and we think, oh, am I already here? That is also a form of dissociation. So there's nothing wrong. There's nothing scary about dissociation. Only the amount of dissociation and the way people dissociate can differ a lot in PTSD if you compare it to common people. So that is another thing that people talk about, dissociation. That's different from DID, dissociative identity disorder, where we talk about different alters. And the other thing the first question was about repressed memories. That is also a form of dissociation, but that is different. So we do believe that sometimes people tend to forget things and they come up again. It's not that they were unaware of it, but they remember it again. Like sometimes I will tell you something when you were little and you say, oh yeah, that's true. And so you can also have these things happening. That's also not really rare. That happens also with PTSD patients. And of course, they tried hard to say it didn't happen. And they pack it somewhere away and they don't think about it. It can happen that these memories come up. But you say that it's difficult if you treat them in an outpatient setting. Well, I'm the director of the Utrecht Academic Anxiety Center. We have an outpatient intensive treatment program. We don't do intensive treatment program inpatient like in Cytrac. And actually, Cytrac has also changed in the last year or so into changing it more to an outpatient setting. And we like the idea that it's outpatient also because then people have also more opportunity to practice at home with what they learn, because that is eventually the situation where they have to go back to. Yeah. Sure. So I think we don't have to mix up different concepts. That's one thing I wanted to tell. And the other thing is that for some things we don't have evidence yet. or there is no evidence. That doesn't mean I'm saying that people do not perceive themselves that way, but the amount of people that really have DID is very, very small. Yeah. And
Mhm.
so the
So,
main issue we are
and
talking about is
yeah,
dissociation in general.
and we don't see it as severe. We see it as a coping mechanism. And I think also that many other experts see it as a coping mechanism. So we see so many patients say, what Suzy was referring, it didn't happen, it didn't happen, it didn't happen with my uncle, my grandfather, and even my mother. So and they try to hide it away for themselves because the truth is unbearable.
Yeah.
And sometimes there are triggers in their life and get emotional about it, but particularly when they are going into an intensive program or in another program. Maybe intensive program is more difficult even to hide it because you're going through all these sessions in our centers, 4 sessions a day. It's very difficult to hide it.
Mhm.
So they, on the one hand, they want to hide it for themselves, and the other ones to get rid, the ones to get rid of the symptoms.
Right.
And then suddenly it comes up, but they look overwhelmed. But if you ask them about it, they don't see it as they knew
Mhm.
that it was there and they wanted to hide it. And they used all their coping capabilities and now it's there. And afterwards, most of the patients say, I'm glad that it came to the surface. Now it can be treated. But in and they tell you in my previous 30 years of therapy, they, the therapist helped me to get it to keep it in the dungeons of my brain
Mhm.
because
Right.
the therapist was teaching me coping skills all the time to keep it away, and I became an expert in coping skills. And also, what we see as DID, we see it as a very effective way of coping because they say, yes, I have these towers in this is my castle, and that's where I hide my traumas. And the towers are my um, identities, my altars.
Mhm.
And what happens in therapy, I say, I bring up my other identity and therapists going to talk with that.
Right.
And it's so nice because I don't have to talk about my trauma because the therapist is taking all this time to talk with my coping mechanism.
More to come in the second half of this conversation. Odd and Suzy have some great online trainings, especially at the website EMDR Advanced Training and Distance Learning. Also, be sure to look at Cytrek's own website, where you can read the peer-reviewed, published research that they're quoting in this episode. If you're enjoying this conversation and you're a clinician treating complex trauma or a student learning how, email dissociativetable@gmail.com to join the discussion on the Clinicians Only discussion board. Folks are going to notice watching this podcast that when I asked that devil's advocate question, because I knew what your answer was going to be, it's as though we're speaking two different languages, right? There's an American language and a European language. And
No,
that's
I don't.
that's
No,
what
no,
I
no,
was.
no, no. I don't think it's American and European language. I think there are many Europeans that also have this way of working with alters and with parts. I think the Dutchies are maybe a little bit more on the forefront
Mhm.
and uh, trying out new things and trying to do a lot of scientific research on this part. But I also see a lot of American colleagues that now work just as we do. So it's not, I think, American European. So I think a lot of Europeans also do it this way. And I think more and more Americans also do it the other way. Yeah.
If you look in the literature, in the research, if they would read the research and just don't stack it away, hide it away, because not many people want to learn that they were wrong.
Well, Dr. Mansfield made that point when he was on this podcast that if you've invested 20 years in creating a theory, it's kind of tough to admit that maybe there's a way of doing that in a couple
Sure.
sessions
Sure,
if
that
you've
is
been
of course
working.
true. And we get a lot of people that are sometimes a little bit angry. They say that it's that people fall short something in the therapy, that there is not enough room for reprocessing, for example. But it's it's not true. It's, I mean, of course you want to find something to say something bad about intensive work or about EBR 2.0. But for example, reprocessing is an excellent example because, well, in if we look at prolonged exposure, for example, there is nobody mentions reprocessing. Nobody mentions context change or person changes or changes from the images or whatever. Nobody talks about that in prolonged exposure. You talk about exposing somebody to the horrific memory as if you are there again, re-experiencing it. But also after these sessions, you find that people do have context changes, that they do apparently did some reprocessing. They think, I was only a little girl. So they have different perspective on what happened. There was no attention for that at all in therapy. And with EMDR 2.0, some people think that we don't allow for associations or something, but we do allow for associations. The only thing is that you will see that they will come up less because the working memory taxation is so much more than you have in regular EMDR therapy. But still, it is allowed to do associations. If they come up, we still say follow it and go with that. So there's no issue in that. But people say, yeah, there's less room for reprocessing. Well, up until today, we still don't know if the reprocessing takes place because of the SUD decline, or if reprocessing first takes place and then SUD decline comes. So we don't know that. And it's very difficult to research that because this is a process that takes place internally. It's really difficult to get a grip on that. But what we do see is we see these context changes even also after the sessions, you know? So maybe it's just us as therapists that we like to ask what comes up, because the first few studies that Francine Shapiro did, she never asked what comes up. That was only implemented into the protocol after therapists said, well, my clients, they report such a beautiful thing. They report this and they report seeing that, and they they report experiencing this and that. So then they added it to the protocol. But before it was not a part of the protocol, and EMD
EMD
just works
didn't
fine.
have it.
So I'm not
Yeah.
saying 2.0 is EMD. I'm not saying that because EMDR 2.0 is not EMD. It is also reprocessing. But yeah, actually, we still don't know if it's that important to ask for it.
But I was thinking to add, I think sidetrack couldn't exist without EMDR 2.0. And that means normally we thought that this would help to bring the SUD down, and if people, in our conceptualization of it, people bring up a memory, keep it in their mind, get distracted by the fingers of the therapist. You can do two things at the same time. We call that working memory taxation.
Mm-hmm.
But I was always convinced that this would be helpful if the SUD wouldn't decline. It has to do with the fact that I was not moving my fingers right. But now, if you see these patients that were hypervigilant for about 30 years or 40 years, because they were saying, okay, I trained my mind all the time because I can listen. And when I go to a party, I can listen to that talk and to that talk, and I hear and because I'm always on, I'm always hypervigilant. And therefore, you train your working memory very, very good. You can do 4 or 5 conversations at the same time while talking with another, with a friend at a party. So these are the people that have a very high very large working memory.
Mm-hmm.
So it's not easy to text them. And if you do only this, you don't see this what I'm doing is very slow eye movements. It's what they called bilateral stimulation, but it's not working memory taxation. So in the beginning, I thought making eye movements will get the SUD down, but sometimes you need more working memory taxation to get the SUD down. But also what you do is keeping the patient within the window of tolerance. So what you are saying, people are getting hypervigilant during in a session with a lot of emotions and panic attack. We don't see that anymore because our working memory taxation is so much, people don't have these terrible high level of emotions anymore. So by keeping the patients within the window of tolerance, by doing high levels of working memory taxation, people don't dissociate and don't get overwhelmed by their emotions or by their memories.
Yeah.
Right. There's so many ways to go with that. I was thinking of going away. I hadn't even planned on that. I have a question from where I was speaking about Sonder that, he did 4 episodes here, and some of them have come out already. But first, yeah, just when you were mentioning DID, right? Like I noticed that when I spoke about dissociation, it went to DID, and that's not unusual, right? Because in America, it's like sometimes every other client has DID. I try to remind people to use like this is
that's impossible.
That's no. And I think that the fact that Francine Shapiro made a mistake here, because when the SUD doesn't go down, I would say, hey, do more effort, put more effort in working memory taxation. But if you don't do that, and that's part of the EMDR 1.0, is that you are very confident that the SUD will decrease if you do bilateral stimulation. But what is the explanation if the SUD not go down? Francine Shapiro said, and it's not Francine Shapiro, but there's a working group, including Sandra Paulson. They were saying probably there is a DID there, or probably dissociative disorder. So it became an explanation. If the SUD is not going down, there has to be an explanation. And it's not, you're not going too fast, you're going not fast enough, your working memory taxation is not good enough. No, the explanation is the patient should have a dissociative identity or a dissociative disorder. That's the only explanation in the bilateral stimulation model of Francine Shapiro's. The only explanation, because you're doing this bilateral stimulation, the SUD doesn't go down. What's the explanation? You have a dissociative disorder. We would say, hey, the SUD is not going down. Probably your working memory, your taxation is not good enough, or the patient doesn't have the memory in mind. It's also an explanation. And it's not in Francine's book, the idea that you don't have a working memory, the patient don't put their memory in the working memory because they are too afraid to do that. And we have solutions for that in EMDR 2.0 too.
Well, the idea is Jesse's not associated with this podcast at all, but so I'm only mentioning him again because it's almost a coincidence. But we were talking about, okay, what might it be that we're teaching that makes new EMDR clinicians so hesitant and so fearful that they're going to overload their clients? Because the constant problem 99% of the time is, maybe more, is underloading, right? Just like you mentioned. And the exposure actually reduces the overload. Like you have a lower dropout rate with EMDR 2.0 with sidetrack. But
the dropout rate is 2%.
2%. Yeah.
But also, the dissatisfaction. I sent you that slide, Suzy.
Yeah.
4,000 patients. What is a dissatisfaction? 3%. 3%. So 1%. Yeah. So 2% that are dissatisfied. This because their diagnosis was not lost at the end of the 4 days. That's 2%. The other one, only 2%, and the other 1% is that the diagnosis was lost in 4 days, but still dissatisfied. 3%.
Mhm.
So the 97% is satisfied with their treatment.
Mhm.
Try to find that somewhere else with another type of treatment.
Yeah, and so to rewind just a second, one thing that reminds me of is so it's what you mentioned is my coping, the therapist is interacting with my coping mechanism.
Oh
Yeah,
yeah.
what I have learned and what I try to tell my consultees is the client may tell you that they have no memory of this, but they're speaking to you. And speaking to someone else, they may have told them about Uncle Ernie and what he did in the basement, to use Dr. Paulson's euphemism that she commonly uses. But yeah, so okay, so folks need to keep that in mind. One thing that Dr. Manfield did say is like, if this method works for you, whatever that may be, psychoanalysis, whatever it may be, like by all means keep using it. Like certain clients prefer certain things. But then there's the criticism, like if you're not healing the client, you may be part of the problem.
Yeah.
But thanks for listening. Well, that was lively, right? So I really enjoyed that. Thanks to Ad and Suzy. I'd like to remind the audience, if you are a psychodynamically oriented trauma therapist or otherwise may have some objections or some questions, would like to remind you that in the episodes with Sandra Paulson, she is starting treatment with dissociative symptoms and also doing brief treatment. In fact, often a 2-day treatment. Rather successful herself, but that's very, very difficult to research and very dependent on strength of her own personality, which we all can aspire to. Likewise with Ad and Suzy. So in any case, one thing that likely needs clearing up, and I pointed this out to a degree in this episode when I spoke about different vocabularies, which I think Suzy pointed out correctly is not American and European. Um, Well, the thing to look at, I think that we all ought to look at is the word dissociation. What do we mean? It gets thrown around, and I tell my consultees that can be used, as I've counted, 6 different ways, probably more. 3 as a verb, 2 as an adjective, and 1 as a noun. So I think they're all valid, but I think we got to get on the same page when we talk to each other about what we mean. Odd and Suzy here were using the very scientific description from the DSM, referring to dissociative symptoms, depersonalization, derealization. And to a degree, often Suzy would speak about another way of using the word dissociate, which is just like an affect intolerance issue. That when we can't take something, we just sort of zone out of it. And that gets used quite a bit. For instance, someone using a particular therapy will say, well, my client just dissociated. Um, so that doesn't necessarily, as Suzy pointed out, imply a dissociative disorder. It could be an anxiety disorder. So another way that it gets used is just for pure space out. I prefer to use the word space out. But dissociate into a part of self. If you're, a therapist who works with parts of self, that's another way that word gets used. Um, you can see how confusing these things could give people dissociative disorders who do not have dissociative disorders, or mess up with case conceptualization otherwise. Another way to look at it is, well, you may have clients say, well, I had a dissociative experience, by which they often mean depersonalization. But the original use of the word dissociation is by the guy who coined the term, it's Pierre Jongh. And his work has been picked up by one of my heroes. Notice that book back there? Well, actually, it's on that side, right? So The Haunt itself, right? So Anna Vanderhart and his colleagues originating the theory of structural dissociation of the personality, which Odd and Suzy pointed out has no basis in research. Again, how do you research that? Maybe one day we can. I find it validated by experience. Some people might say I'm imposing that on clients. I can say with certainty that I'm not. It just gets reported to me. And once you've heard the same thing about 3 dozen times, you start to say, this haunted self book kind of explains what I'm seeing. The original use of the word dissociation, of course, has to do with just a split in the mind, exactly what it implies. Trauma time, real time. More than one part of self in trauma time because more than one defense system blew, or otherwise there was severe attachment wounds through neglect. Well, dissociation between those defense systems. So in any case, I think that's worth discussing. So check out the discussion board and you may want to discuss it. I'll stick it up on there as a topic. In the next episode, I go completely off script and we start to talk about the flash technique. I think you'll really enjoy that because Dr. Manfield had suggested in an early episode that EMDR 2.0 is actually just a really complicated way of doing flash. So that produces an interesting conversation and led to the Adventures in Synergy series of episodes that I've been doing. Hopefully another one of those will come out soon. So I hope that you also will experiment with the ideas on this program, stick them together, see what you get. Again, you don't have to be a PhD to play around with what works with your colleagues and discuss things. And that's what I made this program to inspire. As always, our intro and outro music is provided by the band Crack Machine. They've generously donated the rights to their music in support of global access to trauma therapy, and we thank them so much. Until next time, see ya.